Hi, everybody. This is Kathy Randall, and this is your aEEG interpretation training in 1 hour or less, let's hope. And I'm just going to quickly get started here. I just want to encourage you to just embrace this experience and let's take a plunge into aEEG. So we're going to get started with just the basic definitions. What is aEEG? aEEG stands for Amplitude Integrated EEG. So by amplitude, we really mean the measurement of a wave. So oftentimes we think of amplitude regarding air waves or sound waves, but we can apply it for aEEG to brain waves. And integrated, meaning a process of combining lots of things into a whole. So amplitude, integrated, and then of course EEG. And so EEG is just those brain wave amplitudes that are recorded as waveforms and are really dependent on the location, the distance, and the orientation of our electrodes that we put on the baby's head. So those electrode locations are called a montage. And so we're all familiar with a 12-lead ECG or even our full montage EEG. Those electrodes have a specific location that are designed to collect a certain type of brain activity or heart activity. When we're talking about EEG electrode placement, there's actually a international convention known as the 10-20 system for naming locations on the head. They give the left side of the head odd numbers, the right side of the head even numbers, and then they give a corresponding letter for a different part of the head. And so the F stands for frontal, C for central, and on and on. When we're talking about aEEG specifically, we actually are only really looking at a limited montage of EEG. We're looking at the area that is under the central and the parietal. So although all these other areas obviously are there, we're not monitoring over these areas. When we want to monitor over specific areas or a more global look, we want to go ahead and get our full montage EEG, where we then place electrodes at all of these locations, and then we can compare them to each other. So again, thinking about our limited montage aEEG, the old original aEEG monitors had only one pair of electrodes. So they used the biparietal or the P3, P4 location, again, P3 being on the left, P4 being on the right, and it created one channel. They could only just look at that one channel of electrodes and that one channel of electrical activity. And so this was integrated from the right and the left side of the brain, and it created one band of aEEG, which is what you can see here on the right-hand side. Well, as newer monitors were developed, people started realizing there were some benefits to being able to monitor more than one channel of aEEG. So by simply adding two additional electrodes, one over the central on the left and one over the central on the right, C3, C4, now we could actually look at each of the hemispheres of the brain independently. So we have one pair, C3, P3 on the left. That gives us an aEEG channel that represents the left side of the brain. And then we have C4, P4 that represents the right side of the brain. So with this montage, we can also still monitor, if we want, between the P3 and P4. And we'll talk about some advantages of doing that in a little bit. So let's start with the EEG. How does EEG get transformed into aEEG? Well, our EEG starts out as again, graphical waveform, both positive and negative deflections. It's measured in microvolts. The heart is measured in millivolts. So this is very small electrical activity. And again, it's positive and it's negative. Well, one of the first things that the monitor does is it actually creates what they call rectification of voltage. And this is where we actually turn all those negatives and we turn them all positive. So we rectify those negative deflections and make them positive. So now we have positive peaks. That's all we have. The monitor then goes along and traces these resulting peaks, the highest peaks and the lowest peaks. And that's what they call peak detection. After those peaks are detected, we go through and we actually squish it together. They squish it so much that that 15 seconds becomes one line on the aEEG. So really, it's the absolute value then of the amplitude peaks. It's representing the minimums and the maximum voltages for each 15-second epoch. So min-max, min-max, min-max. And then each line represents the minimum, and then the upper edge measures the maximum. So the aEEG scale is fixed. It's always the same. It doesn't matter what monitor you're looking at, and it's also known as a semi-logarithmic scale. So from 0 to 10, the aEEG paper is linear. So the plotting is linear. From 10, or I guess really 11, to 100, it's logarithmic. The other thing to keep in mind is that the paper speed and the time compression is always the same for every monitor. And so when we look here, we see these hash marks along the bottom axis where we see the time scale, and those hash marks represent 10 minutes of time. So you remember that I said it takes 15 seconds to make one line of aEEG, so that means it takes about 40 of those strokes to fill in 10 minutes of time. So again, as I said, it's written out at a static speed, and we call this a very slow paper speed of 6 centimeters an hour. And depending on which monitor you're looking at, it's typically going to then be displaying 3.5 or 4 hours per screen of aEEG. So on this particular monitor, this is the brains monitor, and this is giving us 3.5 hours. So in the nursery, we have 3 different monitors that are capable of displaying aEEG. We have the brains BRM3, which is the one that's on the left. It can do the left, the right, and the biparietal or the cross-cerebral aEEG. It has no remote access, and it is just a standalone device. Then second, we have the Moberg CNS device. We have a couple different varieties of them. We have a CNS 100 and a CNS 200, but these also are aEEG devices, and they show the left side, the right side, and the cross-cerebral, or the biparietal, however you want to call it. These are capable of full video EEG. They are capable of remote viewing, and we can actually use them for EEG or video EEG in the nursery. The third monitor we have is the Neon Coden. This is the monitor that is typically reserved for our full continuous video EEGs with consultation with our neurologist. This monitor requires an EEG tech to come up and to apply the leads, and then we typically have our neurologist who read the report. So I want to just show you just a little bit more about the Moberg device because it's not yet being fully utilized in all of its capacities in the nursery. This is what they call a multimodal monitor. So what you'll notice here on this screen, this is just a screenshot of the Moberg CNS monitor. And again, you're seeing the aEEG at the top. That's one of the modes that are monitored with this device. This device also has the ability to stream into it our NIRS data, our physiologic data coming from our Philips monitor, and even temperature coming from either the Philips or the Blanketrol. So these multimodal devices are going to be really great for research long term, but currently we're just kind of using them as a aEEG device. But I just want to draw your attention to the fact that in the future we may be using this for many other things. So just as a quick comparison of all of our monitors, since we do have the 3 types, all 3 of them can be used for aEEG. So no matter what, you should be able to see aEEG. Even on the neon codon, which is the one that the neurologist will be reading the full EEG, we can display aEEG at the bedside. Again, just wanting to show you what aEEG looks like. So it doesn't matter which device you use, whether you're using, again, the Moberg CNS, the Brains BRM3, or our neon codon. They all three can show you aEEG trends, and that's what we're going to be learning to read today. So what are some of the differences? So they all can display aEEG. Well, here are some of the differences. First off, who applies them? If it's the Brains BRM3 or the Moberg CNS, our NICU staff has been taught and has learned how to apply these. If it's the neon codon, our EEG tech applies these. Some of the monitors can do video and some can't. The Brains BRM3 cannot do video, but the Moberg and the neon codon can. The Brains is just a 2-channel aEEG device, whereas the Moberg, although we're using it only for aEEG, could be in the future used for full montage EEG. The neon codon can be both aEEG and full montage EEG. And finally, but definitely not least, is whether or not they can be remotely viewed. So the Brains BRM3 absolutely cannot be viewed remotely. It doesn't have any internet connection at all, whereas the Moberg CNS has limited reviewing capability, only mostly because of how we've set up our structure in our nursery, but in other institutions it's widely used as for remote viewing. And the neon codon, obviously, we use that often, and our neurologists are dialing in for that all the time. So to sum it up, the Brains BRM3, you should really think of it as a standalone device for the bedside, really only for our use. The Moberg, however, is a little bit more sophisticated. It, again, does that multimodal device where we can plug in other bedside monitors. It's expandable for the future, potentially even doing full video EEG with it, and has some great potential for research, which is definitely one of the reasons why we included it in our neuro NICU. And finally, the neon codon. This is the fully integrated device. It connects to our current LPCH network. It does require off-unit support and application and an interpretation, obviously, by our neurologist. So let's dive right in, again, with aEEG interpretation. And so it's important, I think, number one, to realize that there are some systematic steps that you can take as you begin to interpret aEEG. And we're going to start off with the infant story. And when I say the infant story, what I mean by that really is what is causing you to want to monitor this infant. And again, thinking about his or her delivery history, any potential for injury that there might be there. Are you worried about seizures? And the other thing to really consider, and we're going to spend some time on during the next few slides, is gestational age and also medication history. So we want to think about those things as we begin to approach looking at aEEG so that we don't misinterpret something as normal or abnormal when some of these things might be influencing it. So to break it down, there are 5 aEEG patterns. And I want you to think of them in terms of normal and abnormal. So there's one tracing that is absolutely normal for the term baby. It's the healthy, mature tracing. Then there's one that we think of that is very expected for the preterm. And then there are 3 abnormal or potentially pathological aEEG patterns. So in the literature, there are 2 ways that you can classify aEEG, or 2 techniques that you can use. The first is pattern recognition. And so with pattern recognition, I want you to equate it to something that you're already familiar with. Like, for example, looking at our ECG electrodes or ECG patterns. So with cardiac patterns, they have common rhythms, they look a certain way, and those are each individually named. In the same way, with aEEG, there are 5 basic patterns, and each of these 5 basic patterns, just like ECG patterns, have names for them. And we're going to learn each of these names as we go through a little bit more today. The other way or technique that you can classify aEEG is by using voltage limits. And so I want to spend a little bit of time talking about how those limits came to be. Well, first, in order to even identify the voltages, you need to visually trace the aEEG, the part of the band that is solid. And so again, you're going to be looking at the upper margin and the lower margin and really looking along and seeing the parts of it that are solid. So you're looking here at the red line, that's the upper margin, and then the lower margin. And as I was saying earlier, in the beginning of the aEEG monitors, there were really a single channel was the only kind of monitor that existed. And so we call this the classic or the single channel aEEG. And you might also hear it or see it called the cross-cerebral, or it's or biparietal. Some people call it biparietal. And that really comes from the locations where we are classically putting the electrodes. So when we classically monitor, we put one electrode over P3 and one electrode over P4, and we get one channel. So just like I showed you in the previous slides. So it was because this was the type of monitoring that was around since the 1960s, most of the research, early research on norms and expected values came from this single channel. And so when in doubt, if you ever aren't quite sure what your tracing is, always take a peek at the cross-cerebral or even begin with the cross-cerebral or the biparietal look, and then look at some of the other options that are available. So when we're talking about what's normal, and of course the original research was mostly done on term babies as well, we're looking for an upper margin of the aEEG band to be above 10 and the lower margin to be above 5. So you'll see in this example that for the most part, the baby is staying above 5 on the lower margin and above 10 on the upper margin. Sometimes when we're looking for sleep-wake cycling, it can be even more easily visualized by looking at these cross-cerebral tracings. So sometimes if you're not quite sure how mature the sleep cycles are, you can actually change the display to move to the single channel and see if it becomes a little more obvious. On most of the monitors that we have in our unit, we're going to be having the ability to look at all three channels. So this would be either the left, the right, and the cross-cerebral. So one thing that I want you to be sure and note is that when you're looking at the bilateral readings or the C3P3 and the C4P4 readings coming from each hemisphere, the actual tracing might sit a little bit lower than the cross-cerebral does when you're looking at the actual band. So in this particular example, you'll see that it's about 1 to 2 microvolts lower when you actually are looking at each individual hemisphere. So when we talk about the norms here in a few minutes, if we're looking at the bilateral view, you just need to take that into account and potentially switch over to the cross-cerebral view if you're interested to see whether or not, is it spending more time above 5 or not. And the reason that you see these tracings a little bit lower on the bilateral is that the electrodes are actually a little bit closer together. And so remember when I first said these channels are dependent on location. So the closer together that the electrodes are, the less brain activity it's collecting, and so, or the less distance they're apart, therefore the less brain is being monitored. And so you see a little bit of a lower margin with that. But it really shouldn't be more than 1 or 2 microvolts. And for most babies, this is not going to be a significant difference. But if you're really wanting to know kind of the overall maturity of the brain, or you're wanting to see, how close to 5 is it, go ahead and switch over to that cross-cerebral view, which is the classical view, and you can use our norms as greater than 5 and greater than 10 as the cutoff. All right, so let's talk a little bit more about what is normal or expected for a couple different age groups. So first off, we want to talk about the term baby. And what we're looking for with the term baby is a pattern that's known as continuous normal voltage. And the way we define that is by saying that there should be the upper margin above 10 and the lower margin above 5. So we just were showing that in the previous slide as well. So when we look here on this particular tracing, we see that if we trace with our eye, the bottom edge of this tracing is right around 10 or 12. So that is definitely above what our minimum criteria is. The upper margin is above 10, it's way up here at 25. And so in this case, it's continuously normal. So the voltage is normal, but for a term baby, we also expect that there would be an alternation to the band as well. So remember, this is 3.5 hours, and there's not really very much variability that's happening for this baby. It's all just kind of there sitting in that one little band. And so we expect when we would have a term baby that there would be some cycling that might happen every 3 or 4 hours. Some sleep, some wake, maybe some deep sleep, some quiet sleep. But in this case, we don't see that at all. So it is the activity itself, or the background activity, is actually normal, but it's not exactly exhibiting all the characteristics of a fully mature and normal trace. Here's an example of a continuous normal voltage with those alternating cycles. So here we see that the minimum margin is above 5, the maximum margin is above 10, and we have this nice thin, thick, thin, thick, thin, thick, alternating pattern that we would expect for a term healthy brain. What about for our preterm babies? What do we expect to be normal for them? Well, as you could imagine, their brain activity is not quite as robust. And so with those, we're really looking at a pattern that we call discontinuous. So it's not continuously active. It has these periods of quietness or discontinuity. So we still want the upper margin to be above 10, but because there's these periods of quietness or less mature, we allow the lower margin to sit below 5. So here's an example of some babies' tracings that are over about a 10-week period. So we start with our 25-weeker, and we see that the bottom edge is definitely below 5, which is notated by that orange line, but the upper margin is above 10, so that's great. And the same with at 30 weeks. We still see the lower margin is a little bit lower, and the upper margin is there still above 10. And then when we get to 35 weeks, we see that other than our periods of sleep, we actually do have periods that are actually above now 5. So that's great. And that is what we would want to see as the baby was nearing term. So then if those are normal, then what would be considered abnormal? Well, first off, again, we need to be thinking about that term baby. This is expected normal voltage activity for a term baby. So if we see that lower margin is less than 5 for a term baby, that is definitely not what we would be expecting. The other thing we see that's missing from a pattern like this is the sleep-wake cycles that we would expect for a term baby. So again, if this is a preterm baby, maybe this is completely acceptable. But for a term baby, we see no visible sleep cycles, and we consider this a discontinuous trace. So for a term baby, a little bit mildly abnormal. Times when you might see this would be after giving a very heavy dose of an antiepileptic. You might see a baby go into a discontinuous trace for 45 minutes or an hour. The other time you might see this kind of persistent discontinuous trace is when you have a baby who's experienced HIE, especially mild HIE. We typically see a lower border that's a little bit depressed. We see that missing and absent sleep-wake cycles, and again, persisting here for at least this 3 hours and potentially even longer. Well, the next abnormal for a term baby, and even really for a preterm baby, is this pattern that we're showing here. So the thing I want you to draw your attention to is our upper margin is still above 10, but our lower margin on this particular case is very low and flat. There's only just occasionally where we see that the bottom margin is elevated up by just even a couple microvolts. So this is what I want you to look for, is that variability or lack of variability. And when we see lack of variability at the baseline, that's a really strong indicator that you're dealing more with a burst suppression pattern. And so although there may be some extremely premature infants that show a extremely discontinuous tracing that resembles burst suppression, true burst suppression is an abnormal pattern that we don't want to see on any infant of any age. So again, it's moderately abnormal, and depending on how far apart the bursts become, burst suppression is also considered a severe pathological tracing as well. So you can see on this tracing, we still have our upper margin is above 10. We see our upper margin is still above 10. And then the lower margin is definitely less than 5. And you can see it's very low and has very minimal variability at all. So let's continue then. We've looked at continuous normal voltage and discontinuous normal voltage. We've looked at burst suppression. But what about these last two tracings here on the right? And these are the severest of all the aEEG, and they are abnormal no matter your age. So the first one we want to look at is the continuous low voltage. And the characteristic pattern of continuous low voltage is that the upper margin now does not reach above 10. So you can see that the bottom edge definitely is still less than 5, but now that upper edge that up until now has always been over 10 is now not reaching 10 at all. So this, again, continuous low voltage. And for me, what I look for is that upper margin. And if I see that upper margin is less than 10, I know right away I'm dealing with a low voltage trace. As the brain is losing power and ability to generate any voltage at all, we begin to go even to a further low voltage trace, which is the inactive or the flat tracing. And so again, we start with low voltage being less than 10, and then when we get to this inactive or flat, or even some people will call them isoelectric tracings, you see that we don't have any of our upper margins really getting much over 5. So you have a very low baseline, a very low variability in your amplitudes, which results in a very narrow band with primarily all of the activity sitting right there below 5. So those are the 5 basic patterns. And so I want to just give you a tool that I've created here to help you work your way through standing at the bedside and trying to classify this aEEG into one of our 5 patterns. So I've created these 4 simple questions that you can just simply go through and just 1, 2, 3, figure out which tracing you're looking at. So the first question you ask yourself is about the upper edge of the aEEG margin. So you ask yourself, is my upper border above 5? And if it's not, then you're looking at an inactive trace. And so you can basically just go, nope, I don't have my upper margin above 5. I'm right there. I have an inactive trace. But if your upper margin is above 5, then we're going to move on to the second question and do that. So we've already said it before, but we'll go back here again. When do we expect to see this inactive trace? Honestly, never. So we know it's always a very severely abnormal tracing when we see that. So if your upper border is above 5, then you want to continue on to question number 2, which is my upper border of my aEEG above 10? If the answer is no, then you know right away that you're dealing with a continuous low voltage tracing. So remember I said that when we look at that upper margin and it doesn't even reach 10, we know we're dealing with a low voltage trace. If it's not even above 5, then that's when we consider it that inactive trace, which is the one we just did. Again, when is this normal? Never. This is never normal, no matter if you're 24 weeks or 24 years old. It doesn't matter. It's never normal. If your upper margin of your aEEG is above 10, then now we move on to looking at the lower border. And we always are looking for that lower border to be above 5. So if our upper border is above 10 and our lower border is above 5, then we're looking at a continuous normal voltage trace. So when is this normal? It's normal for term. And it's even normal for our late preterm babies, like we looked at earlier, the 35-weeker. But what if that upper margin is above 10, but that lower margin is not above 5? If in that case, now we've got to go to that lower border and look at that variability and see where we lie. So if your upper margin is above 10, but your lower margin is below 5, but that lower margin shows some variability, you're likely looking at a discontinuous trace. In that case, when is that normal? We know that's normal for our preterm babies, but we know that's not normal for our term babies. And lastly, if we look at that lower margin and we see that the lower margin is below 5 and it lacks any of that variability, now we know we're looking at a burst suppression tracing. And in that case, we know that for most babies, this is going to be not an expected or a normal tracing that we would want. In that case, we're thinking potentially if it's an extremely premature baby, it's kind of quote unquote normal, but really we are not expecting to see a true burst suppression pattern for any baby. So just when we put it all together, this is for the term baby. We see that our normal voltage, our continuous tracing is the one that we're looking for. Discontinuous is a little mildly abnormal. Then all the rest are really considered abnormal for the term baby. For the preterm, the continuous, if they're over 35 weeks, is considered normal. Of course, the discontinuous is very much expected, especially for our preterm babies, all the way down to our smallest babies. Burst suppression, true burst suppression, where we have limited voltage, no variability at the baseline at all. That is really not a normal tracing for even a preterm baby. But some extremely preterm babies have a pattern that's so discontinuous it may look like burst suppression, and that's where getting your neurologist involved to look at that would be helpful. And again, continuous low voltage and flat, never normal, no matter how young a baby is. So that pretty much sums up all the ways that you can begin to classify the background pattern of your aEEG. Again, that's the overall strength of the brain or the overall organization of the brain. And after we've looked at that, then we can now make a little bit of a deeper dive and go and look into some of the other characteristics of the aEEG. And so we're going to go through each of these in a little bit more detail. We're going to look at symmetry, stability, sleep cycling, and suspicious areas or seizures. So first we want to talk about symmetry. So we've already just gone through and listened to all the ways that you can classify aEEG. So we look at our upper margin, it's over 10. We look at our bottom margin, it's less than 5. We say there is variability. I'm going to call this a discontinuous tracing. And it looks like the same on both sides, the left and the right. You're like, okay, great, this is a discontinuous tracing and it's symmetrical. But what happens though if that pattern is not symmetrical, but instead it is asymmetrical, and you went to look at one side and you noticed it is looking like you have a discontinuous trace, but the other side does not. In this particular case, we see the right side is again that discontinuous, but the left side is a very low voltage flat tracing. Well, there can be several causes for this. Some of them are cerebral, some of them are extracerebral, and some of them are even mechanical or from the monitor itself. So we're going to go through some of these in a little bit more detail. So first off, we want to look again, here's the same tracing where we have this is actually a different tracing where we have the left side has a normal background, but the right side has a very suppressed tracing. Well, what's causing that? Well, in this particular case, it's actually a baby who has actually had a unilateral cerebral insult. And so you can see here that the baby's had a stroke. They've placed the electrodes over that side and the other side, but you can see that on this right side there is suppressed EEG, and that's resulting in a suppressed aEEG pattern. So it's actually because of this unilateral cerebral insult that we have a suppressed EEG on the right side and a suppressed aEEG. This is one of the values of putting a pair of electrodes on the left side and the right side so that we can actually compare the tracings and see if there is symmetry. If we had only an old brain monitor and we only had one channel, again, it's visible here on the 2 channel, but if instead we only had a single channel, we would end up with a tracing that looked like this. So we would put electrodes just on the biparietal, so 2 electrodes at the P3, P4. We would end up with a single channel aEEG tracing. And you can see here, I put the orange bar at the 5. So we would consider this to be a normal voltage pattern. When you only have one channel and you're pulling EEG data from the left side of the brain and the right side of the brain and combining them together, the good, healthy side of the brain can actually generate enough electrical activity that it actually eclipses the fact that the one side is not offering very much electrical activity at all. So in these cases, these babies went in the old days of aEEG monitoring, these babies went unidentified as having any abnormality, and their aEEG is actually classified as normal. And then when they would MRI these babies later, they would actually find that some of these infants actually had unilateral strokes or unilateral injuries. So the advantage of putting on extra electrodes is that you now get the chance to compare that right and that left. So in this particular slide, I just want to show you really quickly where there is a case of transient unilateral low voltage. So you can understand a permanent unilateral low voltage like the case we just showed before, where we have a baby who actually has a cerebral insult. But it would be very unusual to have a baby have a transient unilateral low voltage. So if we look at the aEEG on the right side, we see that the bottom margin is mostly above 5, showing us a continuous normal voltage. On the left side, for those first couple hours from 22:57 up through about midnight, you can see that on the left side, it was quite concerning that there was this unilateral situation going on. But you can see then that something happened there around midnight, and then the tracing turns a little bit more symmetrical after that. Well, this particular case was actually a mechanical case in the sense of the electrodes were touching. And you know how easy it is with these babies inside the bed for these electrodes to get misplaced. And especially if they're in high humidity and the electrodes are very gummy, they can move around quite a bit. But you can see this picture of before and after and just what a small difference this makes. By just moving that electrode, we go back to having a normal pattern. So anytime you see a unilateral suppression and one that has never been there before and you don't think there's any other kind of medical reason for seeing it, you can definitely find that sometimes just going in and checking the electrodes and pulling them apart and putting that distance back between them, that you actually might resolve the issue. So it is our practice to hydrate our electrodes, but this can actually cause a problem when, such as electrical arcing when overhydration occurs. So this can occur by the hair between those two electrodes getting wet and saturated and arcing the electrical signal between them, basically canceling out the electrical activity. Or if someone inadvertently uses saline instead of water, which conducts a lot more electrical activity and would conduct between them. So this is an example of every hour the electrodes were being hydrated, and you can see the aEEG pattern every hour drastically dropping, and then as they dry out, going back to a discontinuous pattern, and then after someone hydrates, they drop out again, and then go back to that discontinuous pattern, and then drop out again. In the right side, I have no idea what was going on the right side, other than thinking that potentially those electrodes were actually touching on the right side. But I also want to draw your attention to the second band, which is the impedance. And you can see there that the purple line is indicating the electrical impedance that's coming from the anterior or the central electrode, and the black is coming from back, which is the posterior or parietal. And you can see that every hour you can see that that impedance just drop right down as the electrodes are being hydrated, and then going right back up every time after they're drying out there. So I think this is kind of an interesting way to really visually see what's happening when we're doing that hydration. And although it does help sustain the life and prolong the life of our electrodes, it definitely can have adverse effects if we're not careful as well. All right, so that was some symmetry. Now we're going to talk about stability. And we measure stability over weeks, days, hours, and even minutes. So just like we just showed in that previous slide where you saw the aEEG band changing with the hydration, we can sometimes see those changes happening minute to minute and hour to hour. So let's start with a baby who actually was a 29-weeker, has a nice discontinuous trace. See the upper margin above 10, the lower margin below 5, but variable, who received a dose of Ativan right along the same time they received a surfactant administration. And you can see that in minutes of that administration, this baby, his aEEG went completely bilaterally flat. This is probably not the effect that we were going for with Ativan, but this is the consequence of that dose of Ativan. So that change happened in minutes of the administration. And that change persisted over hours. And so here's about 24 hours later, we're no longer flat, but we are definitely not back to our discontinuous tracing. Our upper margin is above 10, barely reaching 25, and the bottom margin is very low and flat. So this is just barely on the right side a burst suppression pattern, and on the left side it's still a very flat tracing really. And even 48 hours later, at least more symmetrical now, the left side and the right side. The bottom margin still very low and flat. Upper margin definitely reaching those 25, so we would consider that our minimum requirement for it to be burst suppression would be 25 microvolts. And so this is a burst suppression pattern, but definitely not as healthy as we saw 48 hours earlier before that dose of Ativan. So with babies with HIE, we're particularly interested in looking at their progression over those first 72 hours of cooling and even out for that first week of life. So with babies who are receiving cooling, we want their aEEG to turn back to normal for their age as quickly as possible. And so you can see in this case that on the left-hand side, on the first day of life, this is a very low and flat aEEG. By the third day of life, we're almost a burst suppression pattern, but definitely not normal, but much improved from 2 days previous. And then you can see a week later, this tracing has completely normalized and is showing us a continuous normal voltage, as well as some of those little lows there, which are our sleep cycling, or at least an attempt at sleep cycling. So for cooling babies, we're particularly interested in those first 72 hours, and we really want to see, as quick as possible, a return to that normal voltage, as well as a return of sleep-wake cycling. And studies have shown that babies who do show that return within 48 hours have the highest likelihood of a long-term positive outcome. So we're very, very interested in looking at these aEEG patterns over those first few days of life. And I showed this already before, but just again to show that some changes in the aEEG pattern are really only appreciated over weeks. And so again, we're looking at a preterm baby and their evolution of their aEEG maturity, again, over these 10 weeks as they're maturing. So changes in stability, what we want to see is improvement or maturation in the case of a preterm baby. We don't want to see it getting worse, and we don't like the way that that one showed with a very, very drastic change in just a few minutes. So one of our final areas where we'll take a little bit of a deeper dive is into looking into suspicious areas on our aEEG. So we've looked at the background, we've looked for those sleep-wake patterns, that thin, thick, we've looked for symmetry, and we've looked for stability. Well, now we want to look and see what about some suspicious areas. So with suspicious areas, I just want to remind you that we're really looking for those subclinical seizures, because what we know is that about 80% of neonatal seizures are subclinical, and that when we do try, we only are able to really accurately characterize clinical seizures about 10% of the time. So what does a seizure look like on EEG? Well, we'll start with the basic definition, which is it's usually repetitive, it's a spike slow wave, and it's rhythmic, and it repeats. And so here is an example of what that looks like. It's going to be showing you a spike wave, and it usually lasts for more than 10 seconds. So the normal trace at the top, you can see it just has a couple sharp waves in here, but there's nothing that's continuous about it, nothing that's rhythmic, nothing that's persistent. And on the bottom two panels, you'll see that it's spiky, there's a rhythm to it. You could cover up half of it and predict what you might see on the other half. And for both of these, they last for more than 10 seconds. Seizures also have a beginning, middle, and end. We say they crescendo, decrescendo. So in this particular example, you'll see we've put the marker, which is the red line, right in the middle of the seizure. This is the maximal part of the seizure. This is a seizure that lasts for 10 minutes. So you can see you're going along and you have this discontinuous tracing, and all of a sudden on the right side, there is this massive change. The change again lasts for 10 minutes. It increases that bottom margin, it turns into an archway, and then it comes down and it goes away. So that's that crescendo, decrescendo. The amplitude of that seizure started out a little bit smaller, got bigger, bigger, bigger. Here we're at the maximum part of that, and then you would begin to see that the seizure goes smaller, 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 and goes away. So here we have this discontinuous pattern with this massive seizure right in the middle. We can also have seizures that are superimposed on normal tracings. These are very challenging to identify because oftentimes they can get mixed in with all of the other normal aEEG variations. So again, we've got a normal background pattern. You see that for the most part, your minimum voltage is above 5. And then there are these periods of interruption that repeat time and time again. But you could get mixed up and maybe not see them very well because there is so much variability at the baseline. So when you see this, you've got to just go in, bring your marker, press the review button. Basically, you put the monitor on pause, and you go in and you're able to take your cursor and look in and open and decompress all the EEG pattern that happened for the time before that. So in this particular case, they have the marker there at 12:06, and they've opened up the EEG, and on the right side, you see this very repetitive pattern. Again, it lasts for the whole 10-second window there at the top. And then you see that you've got a repeating pattern, spike wave, spike wave, spike wave, spike wave. And you are definitely suspicious that that's a seizure. So seizures can also be continuous or status epilepticus. And so here's an example of what a status epilepticus would look like on aEEG. So you have this constant seizure pattern that is just disrupting your baseline, and then it abolishes and comes right back and then goes away and comes back and goes away. It's just constant seizures happening. You can't even really interpret the background pattern now because all there is are these seizures. But are all rises in the aEEG seizures? So again, on the left, is that seizures? The one on the right, is that seizures? These disruptions are happening. How can we know? Are these seizures? They certainly are suspicious for seizures, but I won't know until I actually look at the EEG itself. You always have to go in and look to see whether or not it's worth looking at or not. It always depends on what the EEG says. In this case here, we have this discontinuous pattern and we have these interruptions, and when you go inside and you go to review, you can see that there is this repetitive pattern that's happening here inside the seizure. This is a seizure. Here we have an interruption in the aEEG, and we have the red marker there indicating where we are. And in this case, it's not a seizure. When you actually open it up, it looked suspicious. The aEEG was definitely suspicious, but for this particular spot, it is very fuzzy. And in this fuzziness is actually EMG or muscle artifact. This can happen if the baby was crying or the electrodes were placed over a muscle and the baby is shivering. You can see EMG happen for a variety of reasons. In this particular case, when you put the actual cursor here, this is telling you there's EMG. Now over on the left at around 0054, there's another massive uprising. I don't know if that's seizures. I don't know if that's EMG. I don't know if it's movement. I don't know what it is. It's definitely, there are some suspicious areas. And even to the right of the red marker, there are some other suspicious areas. All I can say is those are all suspicious, but until you take your cursor and you go in and you look, there's no way to know. Here's another point, and this is actually just demonstrating there's some suspicious areas for sure over there around 1600, but this particular spot right here where this red line is just demonstrating some ECG artifact that was picked up. And you can see the little blips that are coming along on the EEG, and especially you can see it there on the right and a little bit on the left. Those little blips there are not seizure. Those are actually ECG coming from the heart being picked up at the head through the electrodes. A very common artifact is movement. Again, it can be very high voltage, so it can definitely cause changes to your aEEG band. But again, when you go in and you take your red cursor in the review mode and you open it up and you look, you don't see anything that's persisting and rhythmic. You just see noisy movement constantly, just everywhere. Scribbly almost is a good way to describe it. A very common artifact that we would see is high frequency. And you can see here that you have a very discontinuous, almost birth suppression looking pattern. And then you see this shifting at around maybe 410 or 1410. You see this bottom edge gets shifted up a little bit and is sitting now and riding right along at the 5. Well, this is not brain activity necessarily that's causing there to be this flat bottom edge. It's the high frequency artifact that is so constant and similar from beat to beat to beat to beat that it's causing the bottom margin to just get really flat. The upper margin doesn't really change much. It's still this kind of burst suppression pattern that we see with our upper margin, up there around 25 to 50. But that lower margin is definitely influenced by that high frequency artifact. And that's what's causing that shift in the baseline. Here's another example of high frequency. This is coming only on the left side. So the previous slide was, again, a C3 or P3, P4 biparietal, or the cross-cerebral was what we just looked at. This particular one is giving you bilateral. We see that the right side doesn't have this artifact in it. This is probably because the baby is actually laying on their left side, potentially turned to the left side for this 2-hour period. And while the baby was laying on that left side, probably the electrodes were getting in more contact with the mattress, or potentially a roll that was maybe supporting the high frequency circuit and transmitting this high frequency artifact onto those electrodes and resulting in this very high voltage change in our aEEG band. But again, because that bandwidth is so thin, it's because that EEG artifact, or that high frequency artifact on our EEG is so similar, you're actually seeing that bandwidth get so narrow there. But all of that is just artifact, and the only thing you can really interpret is what you're seeing on the right side there. So definitely we see this a lot, and it alternates. You turn the baby to the right, you see the artifact on the right. You turn the baby midline, sometimes you see it on both sides, sometimes you don't see it at all. Then you turn the baby left, you see a little bit of that jiggle come back in. And really, you either have to accept it if the baby is so critical that you can't really maneuver their head, or you can try to make some movements to the blankets or the boundaries that are around the baby's head that might be transmitting some of that to the baby. So we see this a lot, so just really keep an eye out for it. And the last one I want to show you is not anything that's caused by equipment or by the brain, but by us. And so this is actually someone patting the baby. And again, with our brains device, we don't have video. So unless someone documents, and documentation of events, clinically relevant events like giving medication, doing cares, turning, changing modes of ventilation, all of that documentation is so helpful when we go back to review the aEEG. We don't have video, especially on the standalone brains device, and so we can't see that someone was just patting and consoling the baby here, but someone documented it. So then as we went in, we could actually see, look how rhythmic it is. You would think that's potentially seizures, but thankfully for the documentation, you know it's not. So I can't say again just how much it is important that we document and mark those events as we're doing them as close to real time as we can. So that wraps up aEEG interpretation. Start with the infant's story. What are you expecting to see? What is their age? What are you thinking you might be willing or interested to see? And then go through the steps. Look at the background activity. Look at the sleep cycling. Is it there? Is it not? Do you expect it? Symmetry. We should see symmetry if we're looking at the right and the left. Sometimes we see a little bit of difference when we look at the cross-cerebral, a little bit higher on the band than the bilaterals. We want to see stability. We want to see that either improving over time, but definitely not worsening. And then we want to look for suspicious areas. So those are the 6 different things that you can do every time you go to the bedside. Think about the baby's background, look at the overall strength of the brain, look for sleep, look at symmetry, look at stability, compare the tracing to the previous 3 hours or even just a few minutes before, and then look for those suspicious areas, especially if you have any suspicion that there might have been some clinical seizures. So I hope that this overview gives you confidence so that the next time you see a monitor at the bedside, you'll be willing to dive right into aEEG. I hope you're ready for the post-test. Go back to your email and look for the link, or you may be redirected right now to it, just depending on how the connection is working for you and if your firewall allows it. If not, go back and grab your link to the post-test. And I know that after listening to all of this, that you really are prepared. So just take a deep breath and know that you can do it, and you are ready for your test.